Today we are going to be talking about hearts and cabbage. What do you think these two images have in common?
Brown.
Not quite. It might be confusing, but I assure you, in a moment's time, it will all be clear. Hello and welcome to the CABG Cookbook, an introduction to cardiac surgery. My name is Zoe Rose, and today we will be taking a short journey into the world of cardiac surgery. We will begin with the anatomy of the heart. Cardiac surgeons need a deep understanding of how the heart functions. Then, we will take a walk down memory lane and look at some of cardiac surgery's greatest moments in history. Finally, we will learn about coronary artery bypass grafting surgery, which medical professionals call CABG. CABG is a surgical procedure that we can understand by thinking about plumbing. We can think of the body as a circuit full of tubes that represent blood vessels. That is, veins and arteries. These tubes are very important for our body. The tubes we have to keep our hearts healthy sometimes get clogged up, like the time I flushed my rubber duck down the toilet. When the tubes in our body get clogged, we need a cardiac surgeon and not a plumber. This surgeon will fix the clogs in our heart's tubes through the CABG procedure. This involves using a tube from your leg or another part of your body. This tube is then attached above and below the clog to go around or bypass it. I will be referring to these tubes that we get from another part of your body to go around the clogs in your heart as grafts or conduits throughout this presentation. Before we take a deep dive into the anatomy of the heart and vascular system, we first need to understand, or at least try to understand, some important terminology. In medical terminology, there are three anatomical planes. These planes help us understand what in the body is on the top, bottom, left, right, front, and back sides. Using anatomical terminology instead of using terms like left and right is very important because it reduces confusion and it can be used no matter how the body is positioned. The back of the body is posterior and the front is anterior. The left side of the body is called medial and the right is called lateral. The terms superior and inferior are the top and bottom parts, respectively. These terms can also be applied to individual organs. The next terms that are used are proximal and distal. These terms are used frequently during procedures. The terms proximal and distal can be used to explain positions along a structure. Proximal is closer to the origin of a structure, and distal is further. The heart is located in the thorax. Inside the thorax, the thoracic cavity is made up of two pleural cavities and the mediastinum. The pleural cavities surround the lungs, while the mediastinum contains the heart, esophagus, trachea, and major systemic blood vessels and nerves. The best analogy for the heart is seeing it as a pump, since that's what it is. The pump works because inside the heart there are four chambers, including two atria and two ventricles. There are also four valves in the heart, which keep the blood flowing forwards through the heart. This includes the semilunar and atrioventricular valves. The upper chambers of the heart are the atria. They receive the blood returning to the heart. They also provide the ventricles with blood. The ventricles then distribute blood to the body. Depending on the pressure in the heart, the valves will open or close. The opening and closing of the valves makes the sounds lub and dub. Did you know that a heart removed from the body can continue to beat spontaneously outside of the body without the need for external nerve supply? The conduction system of the heart is very special because it can generate impulses automatically, pass impulses to new cells, and shorten fibers in the heart to allow for contraction. The cardiac cycle explains the process that happens from one heartbeat to another. Two key terms in the cardiac cycle are systole and diastole. The electrical and mechanical systems allow for these steps to function properly. In the most simplified of explanations, this is what happens during systole and diastole. Systole is the ventricular ejection and contraction phase. During the ejection phase, the semilunar valves are open and the atrioventricular valves are closed. Diastole is the ventricular filling phase and relaxation phase. During this time, the atrioventricular valves are open. Okay, enough of me talking. I have a question for you guys. How many kilometers of blood vessels do you think there are in the human body when it's all added together?
8,000.
Not quite. Any other guesses? Yeah, Storm?
I don't actually know the kilometers, but can it go around the Earth like 4 times?
Almost. That's pretty close. Finn?
Can I just go all the way to the moon?
There are actually over 90,000 kilometers of blood vessels in the body. This distance is equal to traveling around the equator of the world more than 2 times. This vast network of blood vessels keeps tissues and organs in the body healthy because they bring red blood cells with oxygen. Now I'm going to take you on a journey through the blood vessels of the body. This way you can see how everything is interconnected. Blood from the right side of the heart is pumped through the pulmonary arteries to the lungs. The blood is supplied with oxygen. The oxygen-rich blood returns to the heart through the pulmonary veins. The blood then enters the left atrium and then the left ventricle. Blood is pumped to the aorta to be transported to the rest of the body. After organs and tissues have received the oxygen, the deoxygenated blood returns to the right atrium. It is then distributed back to the lungs via the pulmonary artery. Distribution of blood throughout the body is extremely important. When the heart stops, the brain and nervous system are damaged in less than 5 minutes. Brain death ensues. The heart itself also needs to be supplied with oxygen-rich blood. Two coronary arteries branch off the ascending aorta. These supply the myocardium and heart tissue with oxygen-rich blood. The right coronary artery starts at the aortic sinus and continues posteriorly to the base of the heart. The left coronary artery starts at the left aortic sinus before entering the coronary sulcus. The left coronary artery divides into 2 different terminal branches. The first branch is a left anterior descending artery, or LAD. This is the most common location for blockages in the coronary arteries to occur. The second terminal branch is the circumflex branch. There are also coronary veins, however, these are not part of CABG. Now that we understand the heart and how it works, we can begin to learn about cardiac surgery. The best place to begin this journey is to explore how this field came to be. The history of cardiac surgery is quite brief, as it has only been a distinguished medical field for a little over 80 years. Despite this, the history is rich and fascinating. Many incredible surgeons have developed this field to be what it is today. The first successful cardiac surgery was performed by Daniel Hale Williams in 1893. He performed a valve repair on a young woman. But it wasn't until World War II that cardiac surgery truly developed into its own distinguished medical field. During World War II, surgeons removed shrapnel and other foreign bodies from soldiers' hearts. Many of the first cardiac surgeries were pediatric. In fact, by the year 1959, 120 congenital heart defects had been operated on with success in Texas. The cardiopulmonary bypass machine was invented in 1955 by John Gibbon. This changed everything. The machine allowed surgeons to reroute blood flow away from the heart, allowing them to perform complex operations on the heart. The first CABG was performed by a surgeon at the Albert Einstein College of Medicine in New York in 1968. Now that we know when the first CABG was performed, we can explore a case study to understand the steps of modern-day CABG surgery. Throughout this case study, we will be following Claudia Miller, a software engineer and golfer from Vancouver. You can think of this case study as an episode of Grey's Anatomy, without the on-call room interactions and iffy medical information. It began when Claudia, a 62-year-old female, was admitted to the emergency room. She was experiencing nausea and chest pain that radiated to the neck and left side of the back, as well as shortness of breath. Claudia was a smoker, and her file showed a history of hypertension or high blood pressure. These are risk factors for coronary artery disease, which is a blockage or narrowing of a coronary artery. Other factors include high blood cholesterol, obesity, diabetes, and physical inactivity. The physical examination showed that Claudia's legs were swollen from pitting edema, and her blood pressure was lower than usual for a person with hypertension. Claudia had symptoms of poor left ventricular function. Her oxygen level was low before receiving additional oxygen in the ER. She was breathless, and her lowered blood pressure occurred because the force at which her ventricle could eject blood was reduced. This also led to the swollen legs from pitting edema. Next, an ECG was performed. The ECG indicated an anterior myocardial infarction. A myocardial infarction is a heart attack. It's also called an MI. Her initial ECG showed ST elevation, categorizing her as a STEMI. We can see in this image that the ST segment, highlighted in the normal sinus rhythm, is not elevated, whereas Claudia's ECG with ST elevation is. ST elevation indicates a total blockage of the affected coronary artery and that the myocardial tissue is already dying. A blood test was taken, and it showed that various heart attack-related enzymes had been released. The chest X-ray was clear. In addition to receiving 100% oxygen from a nasal cannula, Claudia received additional medication in the ER, including aspirin and beta blockers to lower her blood pressure, statins to lower cholesterol, and ACE inhibitors to relax the veins and arteries while lowering blood pressure. She also began antiplatelet therapy with clopidogrel to prevent thrombosis or ischemia. To relieve the symptoms of chest pain, Claudia was given nitro spray and a small dose of morphine. After her initial consultation with the ER doctor, she was referred to cardiology. She was emergently brought to the catheter lab for an angiogram. The angiogram is performed by injecting contrast material into the coronary arteries to see where the blood flow is reduced from blockages. The angiogram showed a blockage in the LAD and a blockage in the right coronary artery. She was then diagnosed with multivessel coronary artery disease and referred to cardiac surgery. Once Claudia was feeling more comfortable, we met with her. We explained the procedure and possible complications. This helped give her more clarity. Oh, cue cards. One moment. This is going so well. Okay. What? Okay. Hi, Claudia. I'm going to give you an explanation of the procedure and let you know what to expect. If you have any questions, feel free to ask. To start, our anesthesiologist will put you to sleep so that you are comfortable during the procedure. Once you are asleep, we will connect you to some technology that will help you throughout the operation. Does this sound okay?
Yep, that sounds great.
Awesome. Once we have everything set up and you are comfortable and asleep, we will open your chest in the center. Once we have opened your chest, we will take a vein from your leg and possibly one from your chest to go around or bypass the blockages in your heart's arteries. This will bypass the blockage to allow for better blood flow to your heart. We will not open the arteries and take out the blockages. We will simply create a new path for blood to flow. Once we have finished, we will close your chest. After this, you will return to the intensive care unit. When you wake up, you might feel a little groggy, and there will be a tube in your throat. This is from the ventilator that helped you breathe while you were asleep. Once you are awake, we will remove this tube. You will most likely feel some tenderness on your chest. This is completely normal, and we will give you medication as needed. It is important to take it easy and avoid heavy lifting after surgery. Once the procedure is complete, we will set you up with some physiotherapy to help your body recover. After a couple days in the ICU, we will move you to the surgical ward for a few more days before your discharge. Does this make sense?
Yes, that makes sense to me.
Perfect. Okay. Now that we have gone over what to expect, I need to inform you about some of the risks associated with this procedure. As with every surgery, there are inherent risks. The most Significant risk is that there's an approximately 1% risk of death, stroke, or a heart attack after surgery. We will do everything in our power to avoid these complications, but there still is always a risk. While we are talking about complications, I need to ask consent for a blood transfusion. If there is any unforeseen blood loss, we would need consent for a blood transfusion. Does this sound okay?
Yes, this sounds good, but I'm not liking the sound of my chest being cracked open.
That's completely understandable, but you will be happy to know recovery is actually relatively quick, and the pain is often much better after around a week. Once we discharge you around day 6 to 7, you will only need some Tylenol. We also make sure to perform the procedure with care, and we won't be cracking anything unnecessary open.
Thank goodness. I still feel a little bit nervous about the procedure, but I'm glad it's all clarified.
Awesome. At 8 a.m. the next morning, Claudia is brought to the OR for her operation. The first step is to put her under general anesthesia, which is the complete loss of consciousness, analgesia, amnesia, and muscle relaxation. Now that we are ready to start the operation, I will put on my surgical cap and gown. So, I have an actual surgical gown here, so I'm just gonna go put that on. Oh no. Okay. Perfect. Look at that. It's very stylish. I don't know how to do the strings.
No, I hold this and you spin. No,
Spin?
Yeah, spin. Oh, you're gonna hold this one.
Which one? Okay.
And then spin. And then I'll pass it.
Perfect.
There you go.
Good thing we have pro.
Yeah. There we go. Okay. After Claudia is anesthetized, we insert the arterial line, PA catheter, and transesophageal echocardiogram, or TEE. We then draw a line on the sternum with a surgical marker and not a Sharpie. On Claudia's leg, the site for the conduit harvesting of the graft is also marked. Claudia is prepped, sanitized, and draped. We then begin the sternotomy to open the chest. This procedure involves dividing the skin, fat, and tissue of the chest to expose the underlying bone structure of the sternum and the tissue of the linea alba at the sternum's base. The linea alba is divided and the sternum is cut in half from bottom to top using a sternal saw. Retractors are used to open the chest cavity. This exposes the mediastinum. The next step is the pericardiotomy, or opening of the pericardium. We do this by piercing the middle of the pericardium and lifting it away from the heart. We burn the pericardium along the middle with electrocautery to open it. We can now see the heart and can assess the coronary targets and plan for the next operation steps. The tubes or conduits used for CABG are harvested from the patient. We know that we need at least one tube, and this will be a vein harvested from Claudia's leg. The assistant performs this part of the operation during chest opening. The conduit for the right coronary artery came from the greater saphenous vein. The assistant flushed the conduit with saline and heparinized blood to remove any thrombotic material and to make sure the graft was leak-proof. Okay. After opening the chest, we were able to see that 2 grafts would be necessary for the procedure. The second graft would come from the left internal mammary artery, or lima, which runs along the surface of the sternum. After we finish the dissection, Claudia receives heparin to prevent blood clotting. After this, we can remove the lima and wrap the graft in a papaverine-soaked gauze. We are now ready to initiate the 9 key steps which make up the CABG procedure. These steps include pericardial Weller window, cannula insertion, cardiopulmonary bypass, vent placement and arresting the heart, marking target vessels, arteriotomies, distal anastomosis, proximal anastomosis, and chest closure. I know this sounds very complicated, but don't worry, I promise you will get it. We have harvested the conduits and we are now ready to perform a standard pericardial well. This procedure removes a small part of the pericardium to drain excess fluid and prevent future buildup. Next, we palpate the ascending aorta to check for any potential plaque. At this point, we can also choose and prepare our cannulation site. Cannulas are tubes that can be used to add or remove fluids from the heart. We use an aortic cannula, and once we have confirmed that the aortic cannula is correctly located, we attach the arterial limb of the cardiopulmonary bypass machine circuit. We then insert a single two-stage venous cannula into the right atrium. Next, we insert and secure a cardioplasia cannula. Okay, once we confirm that the cardiopulmonary bypass lines attached to the aortic and right atrial cannulas are free of kinks and clamps, we can initiate cardiopulmonary bypass. The cardiopulmonary bypass machine reroutes the blood away from a patient's heart and lungs, doing the work of these organs. A cardioplasia solution is used alongside cardiopulmonary bypass. The combination of these two things will momentarily stop the heart from beating. We arrest the heart by initiating cardiopulmonary bypass and administering the cardioplasia mixture. This solution is administered every 20 minutes to keep the heart still during the operation. We then cross-clamp the distal ascending aorta. After this, the heart has been fully arrested. We insert a small venting catheter into the ascending aorta. Regular ventilation of the heart reduces the incidence of gaseous microemboli. Once the heart is truly arrested, we can inspect the coronary arteries and graft sites more closely. We place elastic loops on the sites we will use for attaching the grafts to the diseased vessels. To attach the grafts to the coronary arteries, we will need to work on the LAD first, and then the right coronary artery. To start the attachment, we need to make an incision or arteriotomy into the coronary artery. We have to choose a segment of the target vessel that is straight and disease-free. The segment should also be beyond the significant blockage we are bypassing. After dissecting the fat above the LAD, we can perform the arteriotomy. Once the first conduit is attached to the LAD, we can perform an arteriotomy on the right coronary artery to prepare for the second attachment. Anastomosis is the attachment of the harvested conduit to the vessel. This is an incredibly delicate and difficult part of the operation. We make sure to have good magnification, lighting, and a clear surgical field before beginning the anastomosis. We perform the distal anastomosis of the harvested lima to LAD first. After this is complete, we perform a distal anastomosis of the greater saphenous leg vein to the right coronary artery. When I say distal anastomosis, who remembers what the term distal means? Anyone? Scott?
Away from the relevant organ.
Okay, that's pretty close. So distal is further from the origin of a structure. This means that the distal anastomoses are further from the beginning of the coronary artery. To perform the anastomosis, we first place our sutures into the heel. We place these sutures while the conduit and coronary artery are apart. After this, we pull the conduit and artery together. We continue the sutures until the toe along the furthest edge. We continue until just a little bit around the toe. After this, we switch to a different needle and suture. We switch to complete the side closest to the lead surgeon. We complete this side and apply light tension before tying and securing the ends. After this is complete, we flush both grafts with 100 milliliters of blood cardioplasia. We can identify any possible bleeding at the anastomosis sites with this technique. Our anastomoses are leak-proof and no repairs need to be made. We then need to perform two proximal anastomoses. This connects the other end of the conduits to the heart. We covered the term proximal in the first section presentation. Does anyone remember what this means? Yeah. Rowan?
Closer to the beginning, right?
Exactly. Yeah, proximal is closer to the origin of structure, which means the proximal anastomoses are where the coronary artery structure begins, namely the aorta. We make 2 small incisions in the aorta with an aortic punch. To be clear, this is an aortic punch and not a fist fight. First, perform the proximal anastomosis on the LAD, attaching the Lima graft using a running stitch. Prior to completing the proximal anastomosis on the right coronary artery, we turn off the aortic vent and fill the heart with blood. We begin the anastomosis at the heel of the beveled or sloping edge of the freshly cut conduit. We place the sutures through the conduit first and then the aorta. We pull a thin membrane known as the endothelium found inside the conduit into the aorta. We continue to suture around the edge of the conduit along the aortic incision. The 2 ends reach one another at the toe. Before completing the final proximal anastomosis, we evacuate air in the ascending aorta. After this, we tie the final proximal suture line and remove the aortic cross clamp. Finally, we decide to gradually wean the patient from cardiopulmonary bypass. We inform the anesthesiologist, and he restarts ventilation. Claudia's heart recovers well from bypass, and there is no need for defibrillation or an electric shock to restart the heart. We remove the cannula still remaining in the heart. We also administer protamine sulfate to reverse the effects of heparin. Now that we have completed these steps, we can close Claudia's chest. There is no significant bleeding, so we pack the cardiopulmonary bypass, surgical sites, and mediastinum with gauze and remove the sternal retractor. We systematically remove the gauze and check for the homeostasis of the sternum and mediastinum. Before closure, we place electric epicardial pacing wires on the heart in case of arrhythmias. The next step is to close the pericardium and the sternum. The sternum is closed with metal wires which are placed in a figure-8 pattern. We place a suction catheter in the chest to test for pericardial homeostasis and connect chest drains to suction to clear blood from the pericardial space. After this, we tighten the sternal wires while maintaining alignment to avoid fractures. The next 2 layers of tissue above the sternum are closed with different suture techniques. Claudia's surgery is successful, and we take her to the ICU where she will be monitored and pain medication will be administered as needed. Claudia stays in the ICU for a couple of days and is then moved to the surgical ward. Before she is discharged, we discuss the best recovery options. Claudia decides it is best to quit smoking, and we sign her up for a cardiac rehabilitation group. We give her a prescription for various medications. These medications will support her heart health by lowering blood pressure, preventing chest pain and further heart damage, and diminishing the blood's ability to clot. Since Claudia will quit smoking, continue to live a healthy lifestyle, and take her medication, she will be healthy as a horse. The operation you've learned about today has the ability to save many lives. Today we covered the anatomy of the heart, the history of cardiac surgery, and coronary artery bypass grafting surgery. This is a lot of information at once, but it's truly only the beginning. Cardiac surgery is so complex that it can barely fit into the 1,400 pages of the Johns Hopkins Manual of Cardiothoracic Surgery. Despite this, we covered and highlighted all of the key points. Cardiac surgery is not always pretty, and it's definitely pretty bloody, but it's also a beautiful way to save lives. Thank you to my external advisor, Rosalind, for all of your support throughout this project and also all of your patience. I appreciate all of the time you spent and put into making this project the best it could be. Working with you, who works in this field and knows so much, was an incredible and enriching opportunity. Thank you to my faculty advisor, Carrie, for all of your editing and support throughout this project. I'm going to add this in. Thank you for doing all the clicks. It wasn't part of the plan, but yes, I could not have done it without you. Thank you to Jen for supporting our whole class throughout this difficult process. Thank you to my parents for all of your support and for helping me take my hour-long, very, very boring presentation and turning it into something presentable. Thank you to my friends for all of your support and for putting up with my complaints about this project.
So, Ms. Rose, you've done an incredible job here, and I think with the interaction that you had up here and some questioning, you made it very much more accessible. Felt like we were on Grey's Anatomy. I'm sure Stephanie felt like that. So we're going to turn to some questions from the floor. We're going to start with your advisors.
Sounds good.
Excellent job, Ms. Rose. You did a phenomenal job in this whole process. It was such a pleasure working with you, and I learned so much, although I still wouldn't feel confident doing any of this. I would rather you be in there. I did have a question, and you did touch on this in your paper, but you didn't talk about it in your presentation just for time. But can you give everyone a bit of an idea of the process of becoming a cardiac surgeon, like what that looks like in your schooling?
Yeah, totally. So the education to become a cardiac surgeon takes 18 years after high school. It's a very long process. So it starts off with a 4-year bachelor's degree, which you have to do. And then after that, you can apply for medical school. And medical school then takes another 4 years. And after med school, you can apply for residency. And it's super hard to get into cardiac surgery residency programs. I think like last year, there were only 10 spots across all of Canada. Once you get in, it's a 6-year program. And once you've completed that, you have to take this big exam. And once you pass that, you can do your fellowship, which is a 2-year program, and it's in a niche subspecialty of cardiac surgery. So it could be like advanced heart failure and heart transplantation, or like pediatric cardiac surgery, or minimally invasive cardiac surgery. And that's then 2 years, and it's often done in the States because there aren't actually very many programs here in Canada. And once you've done all of that, you have to get yourself a job, and then you can fully be a cardiac surgeon.
Thank you.
Mm-hmm. Dr. Rosalind.
Thank you. It's been so amazing working with you, Zoe, and getting to meet with you on Zoom. Both you and Carrie. It's been a real joy in my life. So my question for you is, what's the most surprising thing you learned about cardiac surgery?
I think for me, the most surprising thing was how detailed and complex each of the procedures are, like especially CABG, and specifically like the anastomosis and preparing for that. It's all like so detailed, and there's so many like little steps that I didn't think were even there. And I couldn't even include all of them in my presentation, but it's just crazy because in the beginning, I thought I could write about like multiple different surgeries in full detail, and I wouldn't have like a super long paper. And I wrote about one surgery, and I ended up with like a 60-something page paper. So I think I have a lot more respect for how many steps and how complex it all is.
Yeah, I think your first draft of your outline looked like it would have ended up being that 1,400-page textbook.
Yeah. Yeah.
That would have been some editing for us. Questions from the floor? Come on up, Ruth.
Amazing job, Ms. Rose. I have 2 questions for you. How did you get into cardiac surgery? Because there are many different surgeries out there. And do you see yourself doing this as a job later on?
Okay. Well, I think the reason that cardiac surgery interested me so much more than maybe like other types of surgery is because I really understand now how important the heart is. Like as I said before, like if the heart stops, you have 5 minutes and then everything is over. Like the heart is so important for our body. And I think that's what made cardiac surgery so interesting for me. And yes, I definitely could see myself doing this when I'm older, even though it takes 18 years. But
Come on up.
How long will the surgery take?
yeah, so it's anywhere between 3 and 6 hours, but it also depends how many bypasses there are and if there's any complications.
Go ahead, Roman.
Great presentation. For the surgery, is there a reason why the conduit was harvested from the leg and not another part of the body?
Yeah, so there's different conduits that you can use. Like there's a radial artery, there's lima, which we also looked at, and then there's the greater saphenous vein. The different conduits have different like longevities, and some of them last longer and have better results. So the greater saphenous vein was one of those ones that has pretty good results. And the conduit has to be like a vein or artery that isn't like super important for the body, so that once you remove it, like the leg can still function. So yeah.
Miss McBurney.
Great presentation, Ms. Rose. What I was wondering was, I know this is hard to wrap the head around, and I know this is really dumbed down from your paper. When you were researching, was there anything that you found hard to understand, like particularly hard?
Particularly hard to understand. I feel like what made it easier to understand was Rosalind gave me like this website that had a bunch of videos of the surgeries. So like when I didn't understand what like the textbook was talking about, because the words were just like, what? Then I would just like watch a video of what they were talking about, and it made it like a lot easier to grasp for me. Yeah.
How many words do you think you learned, new words for you?
A ton. Like subcutaneous tissue, linea alba, xiphoid process, manubrium, like there's so many words.
Did you have a medical dictionary near you?
No.
Or, I mean, whatever you don't have, but yeah, that would help me. Go ahead.
Congratulations, Ms. Rose. That was impressive. I am just awed at the level and detail and sophistication of your knowledge. I don't know how many university level classes are packed into your presentation, but there's a lot there: anatomy, physiology, surgery. Oh my goodness. So bravo. I'm curious, and just relating to Leighton's presentation the other day with his virtual headsets and things, I wonder if the world of heart surgery is utilizing those sort of augmented and additional ways of experiencing that. Like, are you able to put on a headset and watch a surgery take place?
I didn't research that at all during my paper, but I think that could probably be like an opportunity. They are like working on like robotic or like robot assisted surgery, where the surgeon has like robotic arms to perform procedures, and I think they've been able to do that with like valve repairs. I think I saw that, yeah.
I was astonished, Miss Rose. That presentation was everything from everywhere. It was tied together so beautifully. Do you, in cardiac surgery, like, or when you're doing the surgery, is there any, when trying to job it, is there any other requirements you need? Like, do you need steady hands, or do you need, like, better eyes or something? Any other requirements you might not have gotten with?
I mean, it's definitely good to have steady hands and stuff. I think the one requirement that people don't talk about is like patience, like 18 years. You need to have a lot of patience. And you also need to have a lot of social skills, like working with patients and like explaining the surgery and like calming people down when they're worried about the surgery. So I think there's a lot of social skills that you need for this field that a lot of people don't actually like think about or talk about a lot.
Yeah, you had great bedside manner. Julie, come on up.
Great presentation. While doing your research, was there like something that shocked you the most, like something that you hadn't known that was really interesting?
I think the one thing that shocked me was definitely like preparing for the anastomosis. Like I learned about how they had to dissect like the fat above the LAD when it was obscured. And if that didn't suffice, then they'd have to insert like a coronary probe. And it was like super complicated just to have like good exposure of like the target vessel to prepare for the anastomosis. And I think that was really surprising.
Julie, come on up.
I have a couple of questions for you, so that was well done. As a fellow Grey's Anatomy fan, I don't know if you are, but did you ever look into synthetic conduits?
No, I didn't. I think that is a possibility, but it's definitely not very common. Like synthetic stuff is more used for like valve repairs and like replacements. I didn't look into that, but I think that is something that they might be doing. But definitely using like the patient's own blood vessels is a lot, just a lot better than using some plastic, yeah.
I know you mentioned in your short presentation that CABG is one of the most well-known or most popular surgeries performed. Are there any bypass surgeries similar to the CABG that make it harder than the CABG procedure? Do you have to
Like other cardiac surgery procedures? Well, there's valve repairs and replacements, like insertion of pacemakers, left ventricular assist devices, heart transplantation. Yeah, there's a bunch of different ones.
Are there any that are similar to the CABG but make it CABG more?
Well, there is stent placement. So that's if someone doesn't qualify for CABG because their blockage isn't significant enough, or they don't have multi-vessel coronary artery disease. And then a stent is just placed in the catheter lab, and that's just a less invasive, more simple version of treating coronary artery disease.
Tell people what a stent is and what it does?
I didn't look into this. I'm pretty sure it's just a thing that you put into the artery and it widens it up so that the blood flow is better.
Adrian, come on.
Ms. Rhodes, that was a really amazing presentation. I was trying to follow along that running stitch. I was like, yeah, I know that running stitch. But what I totally lost on, you take a piece out of your leg, you throw it into your heart. What happens to your leg?
Well,
Does it grow back? Is it like a tail on you?
No, it doesn't grow back. The greater saphenous leg vein, it's not super important for blood flow in your leg. So it just stays removed and your leg pretty much stays the same. There's some swelling after, but it's not actually needed really for your leg's blood flow.
You got extra parts?
So it can just be taken out.
Wow, this was amazing. I think you clearly learned an intense amount of information. And yeah, I'm interested to see where you go in your next 40 years of schooling. Thank you.
How much money does a cardiac surgeon get?
I didn't actually look into this. It's a reasonable amount. I mean, 18 years of education on a lot of student loans, you should make you should make some money.
Rosa, do you have a ballpark?
I don't forget the moment, no.
Oh, well, I'd really love to see it. You have a lot of expenses. Go ahead, Ms. Margaret.
Great presentation, Ms. Rose. I was wondering, how do you plan on preparing yourself for, the 18 years of education? Are you going to do anything between now and then? If you plan to?
I don't know. I don't think I have any big plans. I mean, just reading more medical texts and exploring it further when I have time, yeah.
Anne, come on up.
Thank you so much, Ms. Rose. That was so interesting, and it really is a university course. I took it in second year university, and you explained things really well. I really appreciate that. And it's really interesting that you chose that surgery, and it seems to me that obviously it's been refined over the years, but that's a very, again, pencil to paper, hands-on, using body parts and not technology or anything that's synthetic. Did you come across anything in your research that would combine technology with that same procedure to make it more effective or less invasive? It seems to open up. Are you exposing the heart? Are there microscopic ways?
Yeah, so there's minimally invasive cardiac surgery, which just means the incisions are smaller and more directed, and that doesn't work for all CABG procedures, just depending on where the blockages are located and stuff. But that is a fellowship that people can take so that they can have training specifically in minimally invasive cardiac surgery. And then the incisions are smaller and it's just less invasive version of the procedure.
Mm-hmm. That's great to know. Thank you for that. And also, I think the use of technology to help see the heart better or see into the heart cavity better is probably on the way too, like you showed the AI for practicing or learning, but I bet there's combinations of making it more successful.
Yeah, surgeons have to wear like 2 times magnification surgical loops because the coronary arteries are so small. Like you have to wear like big magnifying glasses on your eyes to be able to actually like see what you're operating on properly.
You didn't talk about this in your presentation either, but can you tell everyone a little bit about the other skills that you were learning and practicing while doing these presentations?
Yeah, so on the other side of things, I was doing like sutures at home. I got like a little suture kit and practicing like different stitches. I'm not like super great at it yet, but I've pretty much got the interrupted suture down and the running stitch. So.
How many different types of like sutures are there?
Well, there's sutures are just like that's the material that it is. So there's like monofilament and non-monofilament, and then there's absorbable and non-absorbable. And then like the stitches themselves, there's a ton of different techniques, and like there's one-handed tying, two-handed tying, tying with instruments, and just a bunch of different like stitch techniques that are used for different things.
Okay.
You already want to advance your career. Sheila, come on
Ms. Rose, that was very enlightening in a lot of ways. I felt like I was in a university class. Congratulations on a very well detailed and presented presentation. My first question to you is, I know you've had a bit more background as to what made you to do your presentation on the heart, because you also did some volunteering on heart. Can you tell us a little bit about that?
Yeah, so my first idea for Masterworks was to look at like sex and gender in cardiology. And then I learned about CABG and I was like, that's way more interesting. I want to do my Masterworks on that. But I still had connections to a women's heart health cardiologist, and she set me up with like a volunteering organization, so I did some volunteer work for them, just for fun. Yeah.
And then my second question is the sutures. I've always been fascinated, and I hope you can answer. What do they use as a thread for the actual suture?
Yeah, so there's different ones and they're used for different things. The most common one for cardiac surgery is polypropylene, and that's the material. And it's non-absorbable, which means that it doesn't like, it stays there and it doesn't just like melt away after a while. Yeah, it's a very sturdy material.
Now, I know you're very, very capable, but your one statistic that actually shocked me is that there was only 10 placements in all of Canada for the field that you're looking at going into. What can we as a school, as an education institution do to help maybe enlarge that capacity?
I'm not sure what specifically like you guys could do, but I just feel like making the field maybe more accessible and also something that's like more common. I feel like it's kind of like one of those things, 18 years of education, like it's one of those things that not that many people maybe want to do even. So just like bringing more awareness about how interesting the field is and making more people excited about it.
Well, thank you and congratulations.
Thank you.
Last question to Rowan.
Great presentation. So for the tiny veins, is there any special material or like tools used to stitch it?
Yeah, so for the anastomosis, polypropylene suture is used, and it's just a running stitch.